There are again two types of stroke. We have ischemic and hemorrhagic stroke. Table. This is 2031. So side-by-side comparison of ischemic and hemorrhagic. Keep in mind there are two subtypes of ischemic. The ischemic stroke caused by blood clot can be embolic or thrombotic. Embolic means it's an embolus or a traveling clot, which means the clot originated elsewhere. Clot did not form in the carotids or the cerebral arteries. They formed usually inside the heart or in the leg. So that means the patient has risk factors for DVTs and PE. You still remember there are two fatal dysrhythmias that cause blood clotting last semester. They are atrial fibrillation and atrial flutter. In the case of thrombotic stroke, risk factors here, of course, will be the same as metabolic syndrome, which means the patient has atherosclerosis. So it's not really any different from risk factors from acute coronary syndromes. Okay, it's the same. This just happens to be affecting the carotid or the cerebral arteries. Manifestations for each one slightly differs. Look at they will have the same BFAST symptoms, the balance problems, vision changes, facial drooping, slurring of the speech, weakness or paralysis of one side of the body, same manifestations. However, the main presenting symptoms will be different, especially the onset of the manifestations. In ischemic, particularly if it's thrombotic, the onset of the symptoms may not be acute. It may be slowly evolving because the clot did not form immediately. If you think about it, because if it's thrombosis, meaning the clot got bigger and bigger and bigger, meaning the ischemia was evolving, correct? The lack of blood flow is evolving. Whereas if it's embolic, what will be the onset of the symptoms? Acute, because the clot suddenly blocked the circulation. Same thing for hemorrhagic. Hemorrhagic, there is no clot involved here. The risk factors for hemorrhagic are vessel problems. So the three most common causes of hemorrhagic stroke are severe hypertension, meaning uncontrolled or untreated hypertension. So that means one of the risk factors for hemorrhagic stroke is also the use of stimulants. So let's say Garrison attended a party and he smoked, he sniffed some cocaine, and the line was a little too thick. So when he took it, it caused a sudden increase in high blood pressure, causing his blood vessels to pop in the brain. All right, so it can be precipitated by that event. Okay, or let's say he had, let's add 30 years to Garriston's age. So he has weaker blood vessels now, and then he found his wife in bed. He found his 68-year-old wife in bed with another man. He walked into that, and then just that sudden anger caused severe hypertension and then popped. So instead of stopping, so now he had a stroke. So his wife and her paramour continued with him on the floor, just watching helplessly. Terrible, right? So do not react right away. Okay, so calmly get your gun and aim carefully. Eh? Yeah, there's no need to be angry. Okay, yeah, be calm. Make sure your gun works. The other risk factors are arterial anomalies. Let's say a aneurysm. Aneurysm is a weakening of the two walls of the artery. It's usually the endothelial or the intimal layer, and then the medial layer of the artery, meaning they weaken, but the external layer is intact. Okay, it just weakened. So the wall of the artery dilated. It may involve one side or the entire circumference of the artery. Either way, an aneurysm is a ticking time bomb. So once this, you have again another hypertensive episode, and the weakened artery pops, and then you have bleeding. The third is arteriovenous malformation. This is a congenital malformation involving an artery and a vein that is connected. Remember AV fistulas we created for purposes of hemodialysis last semester? This one was not surgically created. So these are formed at birth or in while you were an embryo, meaning an artery and a vein, are they normally connected? No. No, they should be buffered by capillaries, right? Meaning an artery gets smaller and smaller and then turns into a capillary. And then at the other end, the capillary turns into a venule and then a vein, correct? So that should be the structure between the arterial and the venous circulation. But here in this anomaly, there is no capillary buffer. The artery connected directly to a vein. Okay. So what will happen to the vein that is connected to the artery? What happened to the AV fistula? When we surgically created an AV fistula, what happened to the vessel now? It grew big, right? Yeah. So therefore, will it be different here? Exactly the same. So again, it will be precipitated by another hypertensive event. You did not know you had an AVM, and then that's what happened to it could happen to Swinger as well. So same thing, he didn't know he had an AVM, and then he had that hypertensive episode, and then pop. And then he had a hemorrhagic stroke. Symptoms are only these. Patient may have severe headache, sudden severe headache. Of course, that will be followed by loss of consciousness because the acute bleeding inside the brain caused a sudden rise in intracranial pressure, compressing structures of the brain, causing him to lose consciousness, because we'll discuss more about increased ICP when we get to head injury. And then finally, he'll have a seizure, also triggered by the increased intracranial pressure. Meaning we don't see, there is an increased ICP in ischemic stroke, but not as much as in hemorrhagic stroke. You understand?
Yes.
So in ischemic stroke, these are the common manifestations. So when your patients come in like this, we always suspect, oh, this most probably ischemic, but we need confirmation. That's why we need a CAT scan first. CAT scan has to confirm whether it's ischemic or hemorrhagic, because what if the hemorrhagic stroke was a smaller blood vessel? So therefore, the bleeding won't be as massive. So they may not have the headache or the losing consciousness or a seizure. Okay, because it could be just a small artery, a tiny one. Any questions so far? Let's start with the risk factors. So we discussed this earlier in Skills Lab. Let me go back to the other one because it's simpler. Okay, simpler here. So the risk factors for ischemic strokes are the following. There's thrombosis, and we already discussed in coronary artery disease. How do we get plaque in the artery again? Or how do we get atherosclerosis? What were those risk factors again? Okay, metabolic syndrome, and we already know what are the 5 in metabolic syndrome. There's abdominal obesity, hypertension, high cholesterol, pre-diabetes or diabetes, and then high, what is this?
That's from there.
Oh, that's it. There's only 4?
Yeah.
Okay. So it could be cardiogenic, meaning embolic. Okay, definitely embolic. You have a heart disease. You have some arrhythmia or some structural problem inside your heart, leading to congestion inside the heart chambers and then formation of a clot. So therefore, whenever you have a stroke patient, there are two specialists that will be consulted. One is the neurologist. The second is a cardiologist. So on the cardiology side, they will order standard examinations, which is echocardiogram. We need to see um, the patient's heart chambers. Okay, what do the valves look like? Is there a clot there somewhere? And also, you'll be put on a cardiac monitor. We need to see whether you have abnormal cardiac rhythms, and then from there, they'll proceed with further testing. Right. So this is the old name. We used to call it a CVA, cerebrovascular accident. No more. We just call it a stroke today. So here again, it's either for ischemic, it's either thrombotic or embolic. Either way, one or more blood vessels in the brain were obstructed by a blood clot, either thrombotic or embolic blood clots, and caused brain anoxia. Now, in the case of the neck, keep in mind the only way the brain receives blood flow is through the left and right carotids. So therefore, it's not only a CAT scan or MRI of the head, but also of the neck. So when they say neck MRI, they're referring specifically to what? The carotid, but they won't write carotid. They'll just say the neck. But of course, what are we looking at the neck for stroke? It's the carotids. I won't go into the details here because that's not necessary for us. Let's go to manifestations. So we said the most common presenting symptoms are covered by the acronym BFAST. So it's either numbness, any of the following, numbness or weakness of one side of the face or the body, confusion or change in the mental status. So here's the S, the trouble speaking, then the E for eye visual disturbances. This is the B, difficulty walking, dizziness, or loss of balance. And then which type of stroke is this for? Hemorrhagic stroke. Okay. The presenting symptoms, that's why it's not the same for every stroke patient, is it depends on which part of the brain had the stroke. Where did the blood clot end up? Okay, which artery did it block? So therefore, not all stroke patients will present exactly the same way. So that's why we need an MRI, and then that same MRI will determine the patient's prognosis and also the plan for rehabilitation. All right. So it can range from mild, moderate, severe motor loss. Really depends on which part of the brain. I will not test you on that. It's not necessary for us. It's really for the doctor. Hemiplegia is a term. Plegia is paralysis. Paresis is weakness. Communication loss because of, again, depending on the side, which side of the brain was affected. Now let's differentiate these three terms. Dysarthria is a motor problem. If you read this bullet, it says here, caused by paralysis of the muscles producing speech. Now, is speech really purely motor? No, you have to be able to construct what you're going to say, correct? Because if it's just motor, then we don't need the brain. We just need the vocal cords, correct? So therefore, in dysarthria, all this is involving the muscles. The muscles are affected, meaning part of the brain that supplies nerve impulses to the motor part for responsible for speech is affected. So it's paralyzed. So that's why the patient may be totally with it, meaning they can construct their words. In fact, You can differentiate this when you ask the patient to either gesture or verbally communicate. Communicate in writing. You understand? Meaning they can communicate in writing, but they cannot say it. All right. So don't put all patients in the same category. Don't say, oh, he had a stroke. He doesn't know what he's saying. No, because some people may only have dysarthria, but not aphasia. Now, aphasia is different. Aphasia is now a brain issue, meaning nothing's wrong with their motor speech. They can talk, they just cannot form the words. Now, there's two types of aphasia, either expressive, meaning they cannot come up with a coherent idea. Okay, something else comes out. So some patients will say, and oftentimes they can be defensive here when you talk to them, when you ask them, okay, because doctors come in, they always ask them, can you tell me why you came in? Of course, the doctor knows why they came in, right? But they still ask it anyway, because that's part of the assessment. They're trying to assess, is the patient aware? Does the patient have aphasia or not? You understand? So we ask them to tell us, why are you here? And then when they say, of course, some patients will say become defensive because they think that, they're being um, discriminated, I'm old, I'm senile. So they say, oh, of course I'm here. But then they cannot come up with an answer. Yeah, I'm here. They invent something as a result. So therefore, they have aphasia. Okay, they cannot form the idea, or they say some words that don't make any sense. They can still communicate, but then the idea doesn't come across correctly. It's not, they can't come up with a coherent idea. Receptive aphasia, meaning they cannot understand what you're saying. They cannot understand what your instructions are. So therefore, they cannot follow the simplest commands. Most people though have both. We call it mixed or global aphasia, meaning they have both receptive and expressive aphasia. Majority of patients have that. Apraxia is a limited version of aphasia, because apraxia is simply the inability to perform a previously learned action. Name a previously learned action. Can you jump up and down? Do you know how to do the hokey pokey? Well, probably not all cultures, right? But everybody knows to sing happy birthday, correct? Meaning there's happy birthday in all cultures, in all languages. Yeah, we have some form of happy birthday. No, you don't have a birthday song?
Like 7 days.
Like, so how do you do the birthday? Nothing?
No, not me. I'm just
Oh.
saying.
Oh, really? Okay, let's use another example then. You know what water is? Yeah, you know how to drink water, right? Okay, let's use that. That's a previously learned action, correct? Everybody knows how to drink water. When you tell the patient to do that, they cannot do it. Can you drink from this glass of water for me? So it's a previously learned action, correct? But the patient cannot do it. This is more common in dementia patients. So in advanced dementia, late stage dementia, that's why they die, because they stop eating. They don't know what to do with that food. You give them a plate, a tray of food, they don't know what to do with it. That's apraxia. Because they don't know. Yeah, they see it. Okay, I see it. I don't know what to do with that thing. You understand? So that's usually what happens in advanced dementia. So that's apraxia. It's a motor skill. Okay, so to assess apraxia, you have to ask the patient to do something. Understand? Okay. Perceptual disturbances. This is the visual examples I mentioned earlier. So let's talk about hemianopsia. So hemianopsia is different from, this is like partial blindness. Blindness in one half of the visual field. It can affect one or both eyes. Now it can be homonymous, meaning same side is blind, same half, okay, same half is blind. Or it can also be het, I forgot the term. No, you know what? It's just hemianopsia. Okay, so if it's just hemianopsia, not homonymous, meaning the patient has blindness in the whole eye, meaning one eye is either left or right hemianopsia. But if it's homonymous hemianopsia, it's the same half, the same side is blind. The same half side is blind in both eyes. Okay, so either you have let's say each eye is left half blind. So what can I see only? So if this eye can only see, I can see Tenzing, I cannot see Miss Peters, can't see Faith. And this eye can see, no, this is blind, right? Okay, so this eye can't see Jamila, I can see Michael, right? So meaning the patient has blind spots. Whenever they turn, they have to turn their head like this to see everything because they have blind spots. Okay? Well, they have to keep doing this when they drive, which can be dizzying. So yeah, of course, these patients won't drive unless they, of course, have to, then they'll have to. Not everybody has family. Okay? That's a sad thing in this country. Okay, sensory loss. So this will now involve agnosia. So this is another term. Agnosia is not simply, there's different types of agnosia. It can be tactile, it can be auditory, can be visual, it can be also taste. Okay, so agnosia is the loss of ability to recognize an object. Again, differences can be I can't recognize what I'm touching. I can't recognize what I'm seeing. I can't recognize what I'm hearing. Do you follow so far?
Yeah.
Meaning, let's say I give you, whatever I give you, you cannot recognize the object. All right, meaning, you can see this in other disorders as well, but it's present in stroke. Meaning, you give them an orange, they'll say, "I know that. I just don't know the name of that." Okay, they can't recognize it. So unlike apraxia was a command, right? Meaning they can't do something that they knew previously. This one, they cannot recognize something that they're expected to recognize. You understand? So there's a difference there. Agnosia is sensory, apraxia is motor. Other impairments will be involving mood as well as cognition, meaning it will affect intelligence, and then there will be some mood changes as well, especially a frontal lobe stroke, because that's where what functions are stored. Learning, memory, and other intellectual functions are in our frontal, and that some emotions are also there. So these patients will, of course, have difficulty. So sometimes some stroke patients, you see, they still continue to work, right? I mean, I've seen people in DMV, obviously they had a stroke, okay? They walk with one side of the body that's partially weakened, this side can't move normally, right? I know they have a stroke, but they're holding a job, meaning, do they have agnosia, apraxia? No. Okay, so it's only a different part of the body that had the infarction. Okay, so they continue to function. So here are a few summary. Table 62-2, we got homonymous hemianopsia, blindness, double vision, or for motor, again, weakness to paralysis, gait problems, ataxia, and then there's dysarthria, motor, but they don't have aphasia. Dysphagia is common in almost all strokes. So before, it's very important, therefore, during the first 24 hours of stroke, do not feed the patient. They have to be seen by a speech language pathologist. However, I mean, you and me, we can tell, right, whether or not the patient can swallow. So you can do a test swallow at the bedside. So just give them maybe 5 or 10 ml, a teaspoon, 5 ml of liquid, then ask them to swallow. So we call that a bedside dysphagia screening. So you can do that with just 5. The most you can give is 30 ml. That's an ounce. Okay, but I personally start with just 5. Okay, that way, if they choke, only 5 went through, right? Or versus 30 ml or more. Paresthesia, this is, what is paresthesias again? The pins and needles, the, like when your leg or hand sleeps, right? Falls asleep. Then there's the aphasia. Again, there's 2 forms, either expressive receptive, or you can have both, which is mixed or global. And then for frontal lobe, again, the patient will have symptoms of dementia. Okay. Then here are the emotional, which can be upsetting because the patient will have mood swings and they can't understand why they're doing it. Meaning they can be laughing, very happy one moment, and then the next few seconds they're angry or they're sad, right? And people around them, if they don't know that they have it, can get, what's wrong with this person? It's embarrassing. The problem is the patient has no control over this. They cannot. That's the key. They have no control over these emotional deficits. They don't even understand why they're behaving this way. Again, this usually involves frontal lobe strokes. I'm not testing this one. This is for the doctors, but let's just look at the the effects. Okay, so just so you know and understand what's happening when you see people out there in society, in the neighborhood. So if it's left hemisphere stroke, that means where is my affected? Okay, it's the right side, correct? And if I have right hemisphere, my weakness will be on the left. Okay. So what have you seen in society that are working, that have a stroke? Do they have left or right side weakness? The ones that you see out there in the field, that's working, okay? That's functioning in society. If you recall. Both can go outside, but which ones are still functional?
Left side weakness.
Why?
It's mostly the right side.
The intellectual ability is affected in left hemisphere stroke. So therefore, those that have right side weakness, do they have normal intellectual abilities?
No. Left side is affected.
The left side controls the.
Okay, yeah, let's start over. So the left hemisphere has altered intellectual ability because that's the side that is involved in intellect. So these people have right side weakness or paralysis. So therefore, I'm asking, which stroke most likely still functions in society?
Right and left.
The right hemisphere strokes. Okay, so these people, because they don't have altered intellectual ability, so therefore they can function. Although they do have what? Increased distractibility, but this is easily managed with therapy. And then remember, there's not just physical therapy, there's occupational therapy as well, so that's involved there. Okay, but anyway, that's not testable. I'm just showing you what you're observing out there in the field. Let's talk about TIA. Which type of stroke? A TIA, first of all, by the way, is a mini stroke. Since it's only a mini stroke, did the patient really have a stroke? No. This is not a stroke. So therefore, did something die here? Nothing died. So what is the equivalent of a TIA in acute coronary syndromes? What is the equivalent? Because remember, both are involving arteries. So in acute coronary,
And STEMI.
no, and STEMI is an MI. This is angina. Okay, so this is the equivalent of angina, meaning did the patient with angina have a heart attack? No, no myocardium died, right? But was it exposed to ischemia? Yes, that's why they had chest pain. This one, did the brain suffer ischemia? Yes, it was ischemic, but did it die? No, because that means, was the interruption of blood flow permanent? No, it was only temporary. They did have ischemia to one or more parts of the brain, but it did not result in an infarction. Infarction is death. There is no infarction here. There was ischemia though. So therefore, the patient for a moment had a stroke. I mean, the symptoms of a stroke. But we can't tell them apart because do we wait? Because the symptoms resolve in 24 hours with or without intervention. They resolve spontaneously. But when they present, can you tell that it's only a TIA? The patient having, the VFAF, they have this, and then, oh, that looks like a TIA. Don't worry about it. Can we say that?
No.
No, same thing. We bring everybody to the ER, but then either in transit, the symptoms started improving, or later during admission, the symptoms resolve on their own. But in most cases, do we leave them with no interventions? Not even an aspirin? No, we give them a treatment, right? But then the symptoms resolved even without a thrombolytic. But of course, again, we don't take chances. Everybody, whether it's a TIA or stroke, because we cannot confirm whether it's a TIA only. So we send everybody to what? A CAT scan. Then CAT scan will show, oh, there's no evidence of acute stroke. But in most cases, because we have 24 hours, correct? So do we wait? We just let the 24 hours? No. If the CAT scan is not conclusive, doctors want to make sure. Because can you take a chance? No. We send them for an MRI. So CAT scan negative, but patient still has the symptoms. Okay, let's try an MRI. Just make sure. MRI will do a more finer slice. Okay, they'll slice the brain even more. When I say slice, we take more pictures, okay, more detailed pictures compared to a CAT scan. Then it will confirm, okay, there is no stroke. What you had was a TIA, right? But can the patient have another stroke? Yes, meaning a TIA is a warning. It's a sign that you were lucky, that, okay, you were blessed. Okay? You did not have, it wasn't a stroke. You're blessed, but the next one might not be a TIA anymore. So we treat them same way. So all stroke patients, when we get to management, all will be put on 3 medications. Aspirin, Plavix. It's usually dual antiplatelet. Both will affect platelets, but doctors again and the patients would agree, cannot take a chance. We cannot just leave it to aspirin. Let's put you on Plavix also, clopidogrel. And finally, what's the underlying, how did this patient have atherosclerosis again? The cholesterol. So the third will be a statin. Okay, so those are the 3 standard treatments for people who had a stroke. They'll be taking statins, aspirin, and clopidogrel. Of course, if the patient has increased risk for bleeding, they may just be put on one, either aspirin only or clopidogrel only. Okay, but most patients will be on dual antiplatelet because do you want to take a chance? No, it's stroke. I already described to you, the consequences having a stroke. I mean, You can still live, relatively normal, but not at the fullest. Okay, you're supposed to enjoy, your retirement. But again, because most people that have a stroke are already retired, 65 years and older. So that's a TIA. Side by side again, if you look at the patient, it looks like a stroke, right? So we treat them the same way, diagnostic wise. Now, so here, ATI may be a warning sign. So you saw the table on the previous page. Which types of stroke will have a TIA? Hemorrhagic, B, embolic, or C, thrombotic? Thrombotic will have a TIA. Because can an embolic have a TIA? Usually no, because that clot, unless there's a chance, there's a small percentage of embolic stroke patients that may have a TIA because they're lucky that the clot is tiny. Okay, it was a tiny clot. Yeah, that would be an exception. So some embolic stroke patient may have a TIA, but a hemorrhagic stroke, will they have a TIA? No, because the blood vessel will just, right? There is no TIA. So only ischemic strokes will have a TIA. Specifically, which ischemic stroke? The thrombotic will have a TIA. So let's review again. So for diagnostic, what's supposed to be done within arrival of the medical facility? CAT scan. So within 20 minutes, do you want within 20 minutes?
No.
You want 10 minutes?
10 minutes.
Yeah, okay, should be sooner. So, but the book says 20, okay, so be it. So we need to identify first so that we can proceed with the treatment. So we know already from lab earlier, what's the treatment for either type of ischemic stroke, embolic or thrombotic? Thrombolytic. What about hemorrhagic? The vessel pops. So what do you think, without looking at the textbook, what do you think will be done? So how do we stop that? It bursts. I gave you 3 reasons. Severe hypertension, and then we had the AVM, and then we had the aneurysm. So what do we do? How do we repair? So we have to do surgery. We have to open the skull and stop the bleeding and remove the hematoma, right? Because there's a hematoma there. Yeah, that's it. Let's do prevention. Let's say it was a TIA. Do we just say, oh, TIA, you're lucky, go home? What do? We educate, and then we treat, right? Put them on medication. What are those 3 medications again? Aspirin, Plavix. Okay. Let's stop saying Plavix because you won't see Plavix on the NCLEX. Clopidogrel. So it's either clopidogrel. There are different drugs. There's prasugrel also, but they sound the same. There's a O or U and a grill there. Okay. So clopidogrel is the most popular, but we can also have prasugrel and then aspirin. So here's the prevention. So nothing different from acute coronary syndrome. I won't repeat it. Same thing because it's all involving the same atherosclerosis, right? So eat healthy, exercise, stop smoking, lose weight, take care of your hypertension and diabetes. Okay, so no different. So if you compare this to acute coronary syndromes, really the same risk factors. Okay, let's go to management. Depends on what was the patient's risk factor. What was found out based on the diagnostic testing, patient's profile interview. So what caused the patient's particular stroke? So let's start with the ischemic stroke. So once we find out, remember there's a cardiologist, correct? So once the cardiologist sees, oh, it's your heart that caused the stroke. You had an abnormal heart rhythm. So if it's AFib, what do we put them on? Anticoagulants. Right. We'll discuss more on which anticoagulant later under module 6. We'll discuss this part under PE because it's really the same. So if it's AFib or aflutter, we put the patient on some form of anticoagulant, right? And that's going to be pretty much forever, correct? Or is it just a couple weeks? It's going to have to be, I mean, if the patient, expects to not have a stroke, but if they want a stroke, of course, they can refuse, okay? But this is the only way. Put you, because you have a abnormal heart rhythm, we'll put you on anticoagulants. So there are options, if appropriate to the patient. Warfarin is the only option if the patient has a valve problem. There's really no other choice. So if it's a valve problem issue and they develop AFib from that heart valve problem, even if we repair that heart valve, the fact that you have a heart valve problem, only choice is warfarin. Everybody else that doesn't have that have a non-valvular AFib, these are the more convenient options. Dabigatran, apixaban, edoxaban, rivaroxaban. Okay, so these are, when I say more convenient, these drugs do not have any diet restrictions. There's no vitamin K restriction. Plus, there's no blood work needed. There's no blood monitoring needed. So that's the benefit of these. These are called 10A inhibitors, factor 10A inhibitors. Warfarin is a vitamin K antagonist. So warfarin, therefore, requires a routine blood work. We need to measure INR at least monthly on these patients. So every month they go to a Coumadin clinic, usually run by a cardiologist. Okay, they have a Coumadin clinic. A Coumadin clinic is just a doctor's office. Okay, so there's just one table, a nurse doing that, but it's really a cardiology practice. Okay, so there's just a nurse specializing on monitoring patients who are on Coumadin or on warfarin. Right, could be a good, if you like something like that. That's all you do until you retire. Okay, you're a Coumadin nurse. Easiest job in the world. So the drugs, yeah, under, well, minimum. Plus your doctor may give you a annual raise to keep up with cost of living. Huh? Yeah, I think so. Yeah, minimums, you start at 65 a year and then go up from there. Plus you can do side hustles, of course. If you still have the energy, you can, because this is just it's Monday to Friday. It's 8 to 5 thing, right? Because they have an answering service anyway. You have to be on call. They have an answering service after hours. They have questions. Then you can work somewhere else after your 8 to 5. If you're a parent, with young kids, it's the best job. 8 to 5, you sit behind the desk, answer phone calls, give instructions. Come here, check the INR, report to the doctor, ask for dose changes, raise the dose or lower the dose depending on the INR. Okay, it's a very easy job. So here's the statin. Okay, so dual antiplatelet, aspirin, clopidogrel, and then your statin. For those with high blood pressure, let's say hypertension is your risk factor, then we manage them. ACE inhibitors usually is the standard. You may be put on calcium channel blockers and beta blockers if you have AFib as well. The thing with calcium channel blockers is, like amlodipine is very effective. However, they also have the side effect of peripheral edema. They cause that. So some patients hate it, so they don't take the calcium channel blockers. For those with inconclusive or what we call paroxysmal dysrhythmias. Paroxysmal means what? Sudden onset and sudden cessation, meaning they're not consistently showing the dysrhythmia. For those patients, we have a new option now. We have a loop recorder. This is better than do you know what a Holter monitor is? Who has ever worn a Holter? It's literally you wear electrodes and wires hooked up to a box and you wear it 24/7. That's a Holter monitor. Whereas a leadless option is they implant a tiny little capsule right here in your hearts. It's a in and out, it's a minor procedure. You go to the OR, 30 minutes, it's finished. It's called loop recorder. So you'll be given a wireless device. So it's hooked up to, wirelessly to your loop recorder, and it records everything. So when you're at home, you have that loop recorder. You don't have to bring it when you're outside, okay? Because it requires Wi-Fi. So you go out, just you go to dinner or you go to work. When you come home, it's within proximity of the loop recorder, starts recording again. Right? Meaning it's meant to, and it's only there for 2 years, and then the doctor will evaluate, do you still need it? Okay, if it's recording, no dysrhythmias, okay, we'll take it out, and you don't need it anymore. And we discussed the thrombolytic therapy. So what's the window again for this to be effective? 3 to 4.5 hours. And we already know how to mix it. And our responsibilities during the infusion. Okay, watch for bleeding, assess the patient's neurologic status. Okay, let's look at this part now because we didn't discuss it earlier. Say the patient missed the 3 to 4.5 window. However, they're still within 6 hours. I repeat, the patient missed the 3 to 4.5 window by just a couple hours. If it's still within 6 hours, the patient can still get alteplase. However, it can't be given intravenously anymore. It has to be given intra-arterially. That means the patient will go to the cath lab, and then the doctor will inject the thrombolytic straight into the affected artery. But again, that's within 6 hours, meaning we only have a few minutes. So let's say we just missed the 4.5 window, but you're still within 6 hours. So let's rush this patient down to the cath lab and do the intra-arterial option. Okay. But again, if they miss the 3 to 4.5 hour window, most likely it's already beyond 6 hours. So this is not a very common option. Okay, so this is just very rare that we just missed it. We still have a chance. Okay, because again, what's the point of doing this if it's beyond 6 hours? There's nothing to save. That part of the brain's dead, right? You understand? Okay, but can we prevent future strokes? Yeah, that's all we could do. Vascular therapies, this will involve usually the neck. So let's say during diagnostic testing, MRI of the neck, oh, your carotids are 90% occluded, one or both carotids. So what will we do? Clean it. So we'll do surgical option. So the doctor will schedule the, we call it carotid endarterectomy. So they will remove plaque from the affected carotid arteries. They'll clean it. They'll remove the plaque, sew it back up, and there you go. So this can be used for acute stroke. This is an option for acute stroke. You're having a stroke now, or it could also be, which is in most cases, to prevent future strokes. So crucial really is the first 10 minutes or 20 minutes upon arrival. We need to establish the diagnosis of stroke. What is it? Is it ischemic? Then what's the option if it's ischemic? Ischemic stroke.
Is it bullet or?
Thrombolytic. If it's hemorrhagic, okay, surgery, we'll do a craniotomy. Craniotomy we'll discuss under head injury because that is discussed under head injury, which is after this one. Here are the criteria. Meaning if you have these, then you can get alteplase. Over 18 years, we established that it is ischemic. Blood pressure is less than or equal to 185/110. It doesn't have to be both because sometimes the diastolic is normal in some instances. So it's either or. Either your one systolic is less than or equal to 185, and then diastolic is no, not n, or diastolic is less than 110. But if one of them are present, we cannot give alteplase. So that means they're shit all up. Yeah. So what can we do? If the blood pressure is 185/110.
Blood pressure.
Very good. That's all we do. So if the patients come in, because I'll explain later when we get to a head injury, why the blood pressure rises after a stroke, because it's not discussed here. It's discussed under head injury. Now, don't let this be a contraindication, meaning if the blood pressure is high, then simply what do we do? Lower it first. So you give an IV labetalol or IV nifedipine. Nifedipine is a calcium channel blocker. So we drop the blood pressure and then we give the alteplase. And then throughout the infusion, since we know, again, stroke will cause the blood pressure to rise. So what do we do during and after the therapy? Keep giving the blood pressure medication. Okay, so you constantly monitor, and then every time it rises, of course, call the doctor. Hey, blood pressure is rising. Okay, give this. Okay. One more thing about this though. Let me explain it now because you won't appreciate it. Let's okay, so here's the reason why blood pressure rises. It has something to do with the auto-regulation of the brain. Cerebral perfusion pressure, CPP. This is a minimum pressure required in the brain circulation to maintain oxygen delivery to the tissues. It has to be between 70 to 110 millimeters of mercury. So CPP formula is MAP minus ICP. So if my blood pressure is 120/80, is that good or bad? Good. What about 100, or let's say 96/67? Is that good or bad? What is the MAP of 96/67? You already know how to calculate MAP. I mean, we finished shock, right? Okay, so in shock terms, is 76 good or bad? Good, because what is the minimum? 65. We really want 70, right? So we want it to be 70 to 100, the MAP. for meaning that that's the minimum MAP for organs to be perfused. But we understand in shock 65 is not bad, right? That's the minimum. So this one you said was the MAP if it's 96 over 67? 76. Okay. What about 120 over 80? What's the MAP here? So this is 76. What about this one? What's the MAP here? 91, 93. Let's come back here. So let's say it's 96 over 67, which is 76. Normal ICP is 0 to 15. Let's say the ICP after stroke is 19 or 18. Let's go conservative, 18. What is the CPP? It's what? 16, 8, 58. Normal CPP is between 70 to 110. And a CPP of less than 60 means that the brain cells are dead because you need 70 to 110. And I mean, it can sustain up to 60. However, below 60, brain cells are dead. With this blood pressure, therefore, is this good for a stroke? No. What about this one? Let's go 93 minus 18. What is this? 75. However, what if the ICP is higher than 18? Then we're in trouble, correct? So are you happy with this number, or do you want this this CPP higher? We want it high. So in all other conditions, especially cardiology-wise, we want the blood pressure to be less than 120 over 80, correct? Because 120 over 80 is pre-hypertension. We want it to be normal, meaning between 90 to 119, correct? Systolic, and 60 to 79 diastolic, correct? This is the only exception. In stroke, head injury, brain trauma, we want the blood pressure to be high. It should be at least 140 over 90. Minimum 140 over 90. So when you get to the NCLEX, and if it's a stroke, head injury, brain trauma patient, do you want the blood pressure to be normal? No, no normal blood pressures for these patients. We want them to be high, between at least minimum 140 over 90 to up to maybe 179 over 109. Okay, so we want it to be higher. What's the reason again? Why do we want it to be high? Because of the CPP. We want the CPP to be high, because when we get to the management later of controlling ICP, it's not very easy to manage to lower ICP, because of all the compartments in our body, we have compartments, right? The torso is a compartment. Arms, legs are compartments. What about the brain? The skull is the most rigid compartment in the body, because unlike an infant skull, is it fused? No, they have fontanelles, they have fissures which are not fused, right? I mean, there's room for it to grow. A grown-ass person's skull, can that move? No, the skull in a grown person is fused. So therefore, any increase in ICP, so there's swelling there, or in the case of a stroke, there's dead tissue there. There's part of your brain that died. So what will always form around something dead? Edema, swelling, inflammation, vasodilation, correct? That's what happens. So therefore, if you have swelling, edema, inflammation there, is there room for it? No. This skull is already full. What are the three things inside my skull? brain tissue, cerebrospinal fluid, and blood. That's it. You cannot, it's already 100%. Is there room for a hammer in there? Can I put a marble in there? No. So therefore, is there room for swelling there? For any edema? For any inflammation? No, I can't afford that. Because any increases, that means what will happen to the brain structures? It's gonna be displaced. Okay, something has to come out. Okay, so let's finish stroke and then we'll get to head injury. Yes.
Do we need the high blood pressure for hemorrhagic stroke too, or just for?
Same, even with hemorrhagic stroke. Yes, we want it to be, I mean, not over 185, 110. Okay, we want it over close to that. So each doctor, each neurologist have their own limit, meaning for some neurologists, okay, 180 over 105, that's great. They continue. I mean, you personally, it's hard to accept, right? I mean, you would want to treat that. I mean, that's ridiculous. Why would I want that high? But they permit it. They call it permissible hypertension because they understand that the higher the blood pressure, the better the brain perfusion. Call this a protective response by the brain. No other injury in the body will have this response, only the brain. So if the brain is injured, it automatically tries to protect itself by raising the blood pressure because it knows that when it's in trouble, it needs to raise the blood pressure because it wants to maintain oxygen flow, blood and oxygen flow to the tissues. It needs to maintain 70 to 110. All right, the CPP, I mean. So of course, this is the limit. If it reaches 105, 110, of course, please treat it. Okay, that's way too high. And here are the other indications, meaning platelet must not be, too low because of course that will increase the chances of bleeding. So no prior intracranial hemorrhage, no stroke within the last 3 months. Meaning if you had a stroke within the last 3 months, you can't receive alteplase again. Okay, because that's way too much. Pretty much your risk of bleeding is too high now. So we finished the dosage. Side effects, we already talked about it, bleeding. So here are the ideas on what to monitor, what body fluids you need to monitor, vital signs to monitor for bleeding, and then strategies to prevent or to minimize the risk for bleeding, meaning don't put in any tubes unnecessarily. Okay, so put it in if there's an order, if it's really necessary, but if we can go without it, try not to put an NG tube or a Foley or extra IVs. Okay, so if you have 2 IV sites, that's good. Okay, don't put 3 or 4. What are they for? Okay, so minimum 2, that's all you need. We need 2 because we may have other drugs that are incompatible. So at least you have a second IV you can put it through. I won't test you on the NIH stroke scale. We already did the Glasgow Coma scale scoring, right? On a previous skills lab. Remember when we did practice? No, Glasgow Coma scale.
We didn't do
You didn't do it?
it. No.
Okay. Okay, we'll do it sometime. Well, okay, we'll do it today then. Okay, so for let's say the patient has no no option for TPA, meaning they have they don't meet criteria. Okay, so let's say they had a stroke, within the last 3 months, or they're on an anticoagulant, they receive heparin in the last 24, meaning there are contraindications for alteplase, so they can't get it. So these are the other options. So we can give heparin only. Okay. Why heparin? Why IV heparin? Why not the oral anticoagulants? This will take effect right away. So we put them on heparin drip. It'll be a continuous infusion. So we know anticoagulants, do they have the same action as the thrombolytic?
No.
No. Thrombolytics will do what? dissolve a blood clot. What will anticoagulants do? Prevent a clot, prevent a new clot. And what will it do to existing clots? Keep them from getting bigger. Okay, because we know our body will eventually do what to the blood clot? Dissolve it. Okay, just varies with time though. The duration of when our body dissolves a clot depends on the size and number of those clots. So that's really the only option. Or if the clot's big enough, we can do an intra-arterial, meaning surgical option to thrombolectomy, removal of the blood clot manually through surgery. But otherwise, they have contraindication. We really can't do anything for the patient. For controlling the ICP, because again, a stroke, there's dead tissue there, so it will cause some brain swelling and edema and inflammation. We will give osmotic diuretics. Now, mannitol is a diuretic, but it's an osmotic diuretic, meaning it will pull water from the surrounding tissues in the brain, put it into the bloodstream, and then the kidneys will eliminate the water. Regardless of the type of diuretic though, what is the effect of a diuretic on blood pressure? It will lower it. So knowing what you know now about CPP, before you administer mannitol or any diuretic, what should you monitor first? Let's say the blood pressure is 120/80. Are you going to give the mannitol? Not in this stroke patient. Okay? It's too low because what's the minimum? We need it to be 140/90. So if the blood pressure is at least 140/90 or higher, can we give mannitol? Yes, but never if it's already below. Okay, too risky because we know the brain needs high blood pressure during the acute episode. Please understand, this is only during the acute moment. All right, during the first few days of stroke. Usually after 48 hours, no more. We don't, yeah, we want it to be normal already. Okay, so this is just during up to about 48 hours, okay, after the stroke. This is what we follow. Understand? Now, this is not forever, okay? I want everybody to understand. We're not gonna have the patient's blood pressure 140/90 during discharge. Are we clear? Of course, we want it to be low because what's one of the risk factors for a stroke? Hypertension. Of course, we don't do this, okay, on discharge. This is only when? During the acute episode, which is 24 to 48 hours. Some doctors go up to 72 hours, but after that, no. Definitely on discharge, please don't permit hypertension anymore. Okay, this is only, so permissive hypertension only when? 48 up to 72 hours after the stroke. After that, please put it back to normal. This is the NIH stroke scale. I mean, it's a complicated assessment tool. I have to go through 2.5 hours of training because to get certification, you watch videos. Okay, the exam questions, you get about 8 to 16 questions, depending on which website you go for the certification. So the test, you need to score 93% or higher in order to pass. And of course, the questions is complicated if it's written. So they show you video questions. So the patients will be on video, and then you score them. NIH stroke scale. Right? So it's not that easy. So it's a minimum 2.5 hours or longer. So we'll skip that. We will only do the NIH stroke scale. All right, so the other interventions are the following. Oxygen. Now, the reason for providing oxygen is if the patient's saturation falls below 95, that means what is the CO2 level? Rises, right? No, that's the CO2 level. 35 to 45, correct? So if your oxygen is low, that means the CO2 must be high. CO2, high CO2, which is hypercapnia, correct? Or hypercarbia, is a potent vasodilator. What is the effect of vasodilation on cerebral blood volume?
No.
No, cerebral blood volume. My blood vessels are dilated because my CO2 level is high. It will cause cerebral vasodilation. So what happens to blood volume in my brain? My blood vessels are wider now. So what happens to the blood volume here? What happens to intracranial pressure? Increases. So do I want my CO2 to be high? No. The only way to drop my CO2 is to raise my oxygen. So you give oxygen. Head of the bed elevation, it must not be higher than 45. So the minimum is 30. On the exam, both on mine and the NCLEX, if you see anything higher than 45, don't pick it. Most textbooks say 30, okay? Because what happens really, if you think about it, if you elevate the head of the bed, that means what's the angle of flexion in your hip? Let's say if I'm laying down, is there any angle flexion? Not at all. But if I raise it here or here, if I'm sitting up, this is 90 degrees. What's happening to the hip flexion? Acute angle, correct? So therefore, what's happening to my intra-abdominal pressure? Increases because my diaphragm is struggling to push down, correct? So therefore, what's happening to intrathoracic pressure if my intra-abdominal pressure rises? Also increases. And what's happening to the venous drainage from the head? Pressure increases. So can my blood from my brain drain normally?
No.
It can't. So you understand the effect of a sharp angle on the hip. So therefore, how do you fix that? Do you increase or decrease the head of the bed elevation? Decrease. So 30 is best. 45, we'll accept that. We can go 45 if, let's say, instead of a stroke, this is now head injury. No, the patient has chest injuries, chest trauma as well. So we need head of the bed elevation, right? But if you also have head injury, or in this case, stroke, 45 is the most, highest possible allowable, okay? 30 would be the best because that's a very small angle, right? So meaning you maximize venous drainage from the head. If we cannot control the ICP at all, we may have to do hemicraniectomy. Have you seen patients who had hemicraniectomy? No, I've seen people with,
One side.
one part of their brain that's missing a skull, like, okay, that's hemicraniectomy. Okay, so where did we put the skull? Where did that skull go? In a Ziploc bag, in a freezer? Where is it? It's somewhere here in their abdominal wall. So if you see the patient with something like that, palpate the abdomen, it's somewhere there. Okay, yeah, they put it there. We put it there because, it's your own body, right? It's a part of your own body. So if you put the skull there, the skull piece of the skull will stay alive. Meaning your body recognizes, oh, that's my skull. What you doing here? Okay, let's give it blood flow. Okay? Yeah, we'll take it out later. But most of the time, these patients are chronic. But for young people, let's say young people, and then they didn't have, we were able to do that timely, so we can return it later. Okay? Yeah, the ones you see who are, have been like that forever, they already suffered considerable brain anoxia, meaning that they don't recover anymore. So there's no point putting it back. Intubation, again, this is necessary if you cannot raise because what happens is when these patients have brain herniation, let me put it this way. Say Say a glass of water. It's a glass of water. If I fill it with water up to the brim, and then I add one more drop, what will happen? It's already full. I drop one more drop of water. What will happen? It will spill, right? What spilled? Is it this drop that I put in, which will spill? Okay, it will just flow toward the path of least resistance, right? So meaning this, since there's no, will this water molecules here spill out? The ones at the bottom? No, it will be whatever is closest to the path of least resistance, correct? I mean, common sense, right? So let's go to your brain. So if this is your skull, say this is our handsome Mr. Adler. Where's the only opening in his skull? The only opening, which is the path of least resistance. Right here at the back, right? No, your nose, you cannot pick your brain, okay? You cannot put your nose and then reach the brain. There are bones there. There's a sphenoid bone, which prevents your finger from reaching your brain. So this is the only open, correct? This is the spinal cord. Okay, the spinal cord comes out to this hole. So therefore, this is the path of least resistance, correct? And you have your cerebrum here. And then what is this part here? The midbrain. And then what is this part? This is the brainstem. Okay, this is the brainstem. Brainstem controls your respiratory rate, your blood pressure, your heart rate. It's controlled by this structure right here. So following the path of least resistance. So I put a drop of water here. Which one will spill? Whatever is closest to the edge here in your brain. So let's say you have a stroke here, or let's say there's a tumor. It's a brain tumor, or you have a head injury, there's a hematoma there's bleeding, or in the case of stroke. So there's inflammation here. So since this is already 100% filled, right? There's 80% brain tissue, 10% blood, 10% cerebrospinal fluid. What will spill out? And the cerebrospinal fluid is scattered all over because there are ventricles here. There are spaces there, right? And blood is, of course, is in the blood vessel. So what will come out? What will spill out? CSF is all over the place. Again, think about it. In this cup of water, which was full already, you added a drop. You said what will spill? Is it this drop? No, it'll be whatever is closest to the edge. In this glass of water here, let's say this head, Adler's head, is a glass of water. We know this is the only opening. What will come out as the pressure increases here? So let's say you had an increase of 10%. Can you increase the capacity of his skull to 110%? It stays 100. It's already full. 80, 10, 10. There is no 99 there. His brain, his brain swelled after the stroke, increasing the brain mass. So therefore, it's now 110%, right? What will you displace? The brainstem will have to come out, right? It's the closest. Don't tell me this part will come out. No, this thing is closest to the exit. It's like we're in a party. Let's say there's a stampede. We're in a nightclub. Somebody started shooting. Who will be pushed out? The ones at the stage or the ones by the door? The ones by the door. So this one's, the brainstem is by the door. So this will be pushed out because it controls respirations, consciousness, blood pressure, heart rate. What will happen to the patient's respiratory rate? It will drop. So what happens to the CO2 levels? It will increase. Okay, so this is the consequence. So that's why here in our interventions, if the patient gets to that level, meaning we cannot control the CO2 level because the patient's respiratory rate is dropped, we have to intubate the patient. Okay, we will have to dictate. We'll put the mechanical ventilator. Okay, patient's breathing only 8. give him 12 minimum breaths per minute. Okay, so the ventilator will give him 12, whether the patient likes it or not. Understand? Okay. Continuous cardiac monitoring. Again, we need to maintain what blood pressure again? Okay, 140/90 or better, as long as it's under 185 to 110. And here again, if it exceeds, of course, this is only for the textbook, okay? Are you gonna wait until it's 220? No, we wait, our limit is at 185, 110, then we start treating it. Neurologic assessments, frequent, has to be maintained. Again, maintain also. Do I need a machine to tell me my CPP? Or can I do that myself? I can do that myself, right? It's a quick calculation, but I already know that my minimum blood pressure must be 140/90 because I know it's hard to lower ICP. I can raise my blood pressure or I can lower my blood pressure faster rather than the ICP. Because again, the skull is rigid. I cannot control. I have very few options when it comes to my skull. And then fever. What is the effect of fever again on blood pressure? No, sorry, on oxygen levels and blood volume. Fever will do what to my blood vessels? Dilate or constrict it? It will dilate. So same thing as CO2, fever is also a vasodilator. So what do I need to do? Make sure your patient has a normal body temperature. Okay. Is it possible patient's temperature will rise? Yes, because it suffered inflammation, right? From the stroke. So it will rise. Glucose. What is the effect of circulation if the glucose is high? Because what happens to the blood viscosity? Becomes thick, very viscous. Is it going to be easy or hard to put blood or circulate blood to the tiny capillaries in my brain? Very hard. So I want to limit it at 180. So do you want 180 or 140? Of course, we want it as close to normal as possible. Okay, but the limit is 180. Any question about your responsibilities? So oxygen, what else? Temperature, blood sugar, okay, all has to be maintained. Head of the bed position is 30. And what else? Yeah, that's it. So these are our standard interventions. So when we get to head injury another time, it'll be the same principle, okay? Because is it a different brain involved in head injury? Same, just a different mechanism of injury. This one is caused by, ischemic stroke is caused by a blood clot, which killed the brain. Or let's say if this is hemorrhagic stroke, which caused rupture of the blood vessel, but the effect is what? If the blood pressure ruptured, what happened to the parts of the brain that was supposed to be supplied by that blood vessel? Still did not get it. So is it still a stroke? Yes, it's still a stroke. What else do you call it? It's still an infarction, just a hemorrhagic stroke. Okay. That's okay. I'm gonna let you go anyway. You want to break now and then come back for another 30 minutes? Okay, see? See? So I'm giving you a break now. Break?
No, let's follow.
Okay.
Let's go strong.
Okay, managing complications. So when the patient has complications, remember, these patients are potentially intubated, right? If we cannot control the oxygen level, meaning if the respiratory rate is really low, we cannot maintain oxygenation, so we have to intubate, right? So now there are complications related to intubation and mechanical ventilation. And of course, is this patient moving? Bedridden. So therefore, what are consequences of being immobile? DVT, pneumonia, constipation, right? Urinary retention. So we have all of those. Skin breakdown. Okay. So here's the prevention. So I talked about the carotid earlier. So this is CAA, carotid endarterectomy. So what they do is, first the purpose. Again, the purpose could be either treat an acute stroke if the neck or the carotids are the cause, or prevent future strokes as well. So after a MRI of the neck, that will confirm how much is the blockage. So if it's severe, 70 to 99, then we definitely need to open it. So opening means we have to clean it. We have to remove the atherosclerotic plaque. So, okay, here's the illustration of how we clean the neck. So the surgery will be here. They'll open the carotid, take out the plaque, sew it back up. Complications for this surgery, of course, there are also complications of CEA. You could have another stroke during the procedure because we may dislodge a clot that was already in there, or we could promote a clot because this is an invasive procedure. Cranial nerve injuries, meaning cranial nerves in the neck. There could be infection or hematoma at the neck, the surgical site. So here are some complications related to cranial nerve injuries: hoarseness, facial paralysis, or tongue paralysis. Here's a summary, table 62-5. So let's go to nursing care now. So we talked about the paralysis. So if the patient does have weakness, paresis, or plegia, paralysis, what's our responsibility? That muscle, that arm doesn't move anymore. So what do we do? Okay, so either the patient moves it with the functional arm, okay, exercise it. We call that, by the way, unilateral neglect, meaning since they cannot feel or move this arm, what will they treat it as? Is it any different from when you have a shoulder bag? I see you have very nice purses here. Can you feel it if I tickle that bag? If I stab it with a needle? No, because is the bag part of your body? No, only if I move it enough and then you feel your body move, right? That's the only time you feel it. But imagine that side no longer feels like your arm. I can't feel that. Okay. Yeah, I know it's there, but I can't feel it. I cannot move it. So what will tend to happen to that side of the body? Is there going to be neglect? Yes. I cannot feel that. It feels foreign to me. So what will happen to this poor arm, to this poor leg? You cannot move it anymore. So what will happen to the muscle mass? Is it going to be prone to injury? Is it going to be prone to disuse syndrome? Yes. So encourage the patient to continue range of motion. Okay. You can't move it yourself. Move it with the other arm. The occupational therapist will work with them on how to dress. Okay. Because we want as much independence as possible. So they're always taught to dress that side first. Okay, whether it's the pants or a blouse or a shirt. Put the clothes over the paralyzed side first, and then examine that. Always examine the arm and the leg. Okay, make sure there are no injuries there. Protect it from injury at all times. Maintain good alignment. Here, preventing, I mean, if you have, because can they have contractures as well? Yes, there could be contractions, especially if it's left in a flex position. So make sure they maintain joints. Okay, hands, keep them moving. Changing positions, of course, for DVT and pressure ulcer prevention. Exercise program. Ambulation, we're not concerned. I mean, we're not responsible for this. It's really the physical therapist, but doesn't hurt if you remind them to maintain the exercises they were taught. Again, enhancing self-care. We have adapted tools, especially if it's just paresis. We do have adapted spoons, cups. They're quite expensive, but they help the patient become independent. So here are some devices used. I'm not testing these. Okay, nutrition. So what's your responsibility again during acute stroke? Do we feed the patient? No, not until the speech language pathologist. But in practice, we are allowed to do our own bedside swallow screening. Okay, just 5 to 30 ml of sample swallow. Can they swallow? And of course, if they fail that, meaning when you do this and then no more, stop. They don't even attempt to put anything in that patient's mouth, because otherwise now you'll have aspiration pneumonia. Okay, bladder and bowel control. Some patients, depending again on the type of stroke, which meaning which part of the brain is affected, some of them will either have urinary retention, which means it's a neurogenic bladder. The bladder does not contract anymore. So they'll have to self-catheterize or have a Foley forever. Some will be incontinent. So it really depends on which part of the brain and how long the stroke lasted. This is pretty much exercise of the brain. This will be under the occupational therapy department. Communication, speech pathology department. We do have the responsibility of communicating with the patient. So part of there will be right here, you already know how to maintain skin integrity, I hope, turning, positioning. So here is how you communicate with patients with aphasia. Chart 62-4. I won't read it for you, but please take note of what communication aids you can and techniques you need to employ. Can you use gestures? Yes, please use gestures. Do you face the patient when you talk to them? Should there be adequate lighting? Do you approach the patient on the bad side or on the good side? Meaning if they're blind, okay, so the functional side, where do you put their personal belongings? On the paralyzed side or the functional side? Okay, please follow these suggestions here. 62-4. Family coping. Remember earlier we talked about the emotional deficits? When they have these mood swings. All right. Plus, when this patient gets a stroke, will they have depression? Yes, because this is a life-changing event. Imagine they were fine yesterday, and today they have a stroke. So let's say this patient was the head of the family. What's the effect here? He was the breadwinner. Okay, so will he feel bad? He can no longer provide. He has young children. Wife just gave birth last week. Okay, so now the wife has to, right, and then him, on the other hand, can he take care of the children? No, he becomes a baby as well, right? So what effect does this on his ego, on his psyche? Okay, so just imagine the cost of a stroke. So can it break relationships? Can the spouse eventually, get tired? I'm tired of taking of you, right? So this can destroy relationships, right? Okay, and then how much more for the patient? Okay, and then this patient may have maladaptive responses, like they'll start, throwing stuff, being angry all the time. Okay, angry around the kids, angry toward the wife who's already, burdened, right? So again, the devastating disease. Okay, so we don't want this. We want to prevent this as much as possible. Sexual dysfunction. Think of a young patient. How's he gonna perform his marital obligations now. And yeah, and then look at the spouse now. What will the spouse do also? I don't want to be Joy's husband. Just cruel, Joy. What happened to, in sickness and in health? Take note that they can still, we'll talk more about this when we get to spinal cord injury, because that's another event that will cause, sexual dysfunction. All right, so we're done.
What about the GSC?
You want to do it today, or we can do that next week? Okay, we'll do that next week. That's it.